Okay, so let's start with fertility because you can't get to pregnancy without fertility, right? So, all right. So here's some basics. We're going to talk about pharmacology a little bit. It's pretty complicated, and there's a lot of things outside of drugs that, of course, can be considered. So I'm going to really focus on the couple drugs we could use and maybe when you use them. But causes is really important in figuring that out. So if you end up going to work in this area and fertility, you'll get really familiar with some of this stuff. But other than that, I want to go straight to the drugs, more or less. But first, the World Health Organization classifies different types of infertility based on these criteria. And really, when it comes to manipulation of different aspects of the fertility or infertility challenges when it comes to women, we're looking at a couple different aspects here. So class 2 is the most common, which is usually associated with polycystic ovarian syndrome, although other things can happen. You'll notice it's pretty much normal when it comes to your hormone levels. So there's not a whole lot of hormonal manipulation, whereas class 1 and class 3 can be more hormone manipulated potentially. Now, that can also be a challenge too, because class 2 tends to have better response to different types of therapies that we have. So when you're talking about manipulating hormones in people that have really low, maybe gonadal hormones or gonadotropic hormones, you have maybe more of a challenge to overcome with that too. So there's a bit of a double-edged sword there. So then again, just to review what we're talking about here, we're talking about follicle-stimulating and luteinizing hormone and how progesterone and estrogen feed back into the hypothalamus and pituitary glands to support those systems. All right, so ovulation is, of course, a key component. So this dysfunction can cause issues with fertility. And for patients with this particular initial kind of infertility workup, one of the first drugs they often try is something called Clomid, which is a brand name. Clomiphene's the generic. And really all it does is it induces ovulation. It's a SERM. So it's similar to the other SERM drugs we've talked about, like tamoxifen for breast cancer, raloxifene for osteoporosis. It just targets different group of receptors. So what it's going to do is it's going to be an estrogen antagonist, and it's going to have agonist effects actually in different areas too. It's going to basically cause a surge in gonadotropin releasing, so like a surge in luteinizing hormone release, and you're going to end up with ideally some sort of induced ovulation just from taking the drug. It's a relatively cheap drug, and it's pretty effective, and it doesn't have a lot of side effects with it. So all those are good things. It's worth trying. The dosing is a little tricky, so I did put it up here. I'm not going to test you on the dosing specifically, but I think it's worth knowing. 50 milligrams once a day for 5 days, and if that doesn't work, you would increase and double the dose for another 5-day course. After you've tried one course, you should wait a full cycle, so about 30 days before trying another one. And then intercourse should be timed about 10 days after the course is completed. So the idea is that you give this drug for 5 days, ovulation gets induced sometime within that next 5 to 10 day window, and then you can get pregnant easier. So that's the idea. It's only effective for WHO class 2. It doesn't really seem to work with people who have low or too high of hormones. You got to be kind of in the normal range to seem to work. So gonadotropin therapy is another thing that can be tried. Menopur and Repronex are the two drugs in this category, and this gets a little bit more expensive and a little bit more challenging. When we're talking about these drugs, we're looking at combinations of follicle-stimulating hormone and luteinizing hormone that are actually extracted from urine of postmenopausal women and then isolated and purified. It's actually a human product of sorts, if you want to think about it that way. And it does require different types of monitoring, where clomiphene really doesn't require any monitoring whatsoever. It's expensive because it is extracting this and isolating it, making sure it's pure and all that type of stuff is not a cheap process, not just like making a drug synthetically in the lab. And so you do get more costs. And it also is associated with higher higher risk of multiple births. Clomiphene, that is associated in some instances, but it's not as high as gonadotropin therapy directly. The thing about gonadotropin therapy where it might have an advantage is people with WHO class 1 might respond better to it, whereas people with WHO class 1 wouldn't really respond well to clomiphene at all.
Are those the brand names or the?
These are the brand names. So these are different types of like synthetic gonadotropin. So it could be like a synthetic luteinizing hormone or follicle stimulating hormone. Not synthetic, excuse me, or combination of the two is what I'm saying.
There isn't like a generic name though.
No, it would be, I think, I don't know what the drug would say. It'd probably just say like follicle stimulating hormone, human on it. Would be my guess is how they label it, yeah.
Are they IM?
That's a good question. Yes, I think so. I don't think they're IV. They're definitely not oral, so I think they're IM. Yeah. Okay. Moving on to another easy therapy to try, metformin. People with polycystic ovarian syndrome can try metformin because insulin resistance occurs, and you can end up with differences in cyclic response with insulin resistance. So some patients might have a really unpredictable menstrual cycle, and by narrowing that down and getting a better glycemic control, you can end up with more predictable ovulation. So with live birth rates, they aren't quite as high as with clomiphene, so you end up with maybe not quite the best option here, but it still is a worthwhile option for a lot of patients, especially if you have somebody who's comorbid diabetic. Definitely a no-brainer in that case. Other things that can happen, weight loss can occur with metformin therapy just from the increase in glucose utilization, so that can also facilitate ovulation as well. Aromatase inhibitors, we talked about these briefly with our two hormonal cancers, prostate and breast cancer. There's not a lot of data out there. They're expensive for the most part, and they aren't FDA approved for this. So they could be maybe a fourth line therapy, third line therapy, something like that. In most cases, you're going to try clomiphene, metformin if you think it's indicated, especially for polycystic ovarian syndrome, and then especially if they have underlying diabetes would be an option too. Aromatase inhibitors would be something you might try later. There's vaginal progesterone, which is a gel suppository tablet. It comes in a number of different forms. It's a natural steroid hormone. And the mechanism is supposed to be similar to using the body's natural response in the luteal phase, which would cause ovulation and support, or would help support ovulation and also support embryo implantation. So if the fertility practitioner is you in this case, if you want to go into this type of medicine and you think that this is the issue, if everything else looks good from all your testing and whatnot, then this could be an option to try too. So it's going to be a local product. It shouldn't have a lot of systemic absorption or systemic side effects. It should mostly be local within the uterus. All right, that's really it for fertility. Really quick, again, there's not a lot of drugs out there, and then when we get into, you can get into like bioidentical hormones and synthetic other types of hormones that just get more complicated and more expensive. So I just wanted to give you a really brief overview and snapshot there. All right, so when it comes to drugs in pregnancy and lactation, sounds like a really general topic, and it is. There is a lot of data out there, and it's sort of like, a little bit of data is, a little bit of knowledge is dangerous in this category. So I always recommend you look it up. I think that I never really feel totally confident in myself when it comes to pregnancy and lactation. Even if I'm pretty sure, I always double check and just look. And you never know, there might be new trials and studies that come out too. Pregnancy and lactation reference, my favorite is this Briggs book. I don't know if you've heard of it or not. If you go into OB, it's definitely worth a practice. Or any practice where you're dealing, like if you work urgent care or emergency medicine, it might be something worth doing because you're going to see a lot of pregnant people that come in probably with various things. And you're going to be like, is this good in pregnancy? And you might not have me sitting right next to you. And when my providers ask me, I open up this book. So, I mean, it's kind of acting like a middleman in some ways. But that's sort of my whole job. So we won't get into that right now. I just transfer data from one mind to another. But this book is really good. They update it pretty frequently. Unfortunately, there's not a great electronic reference, which I know really is awful in this day and age. We all like to have things at our fingertips, and I certainly like that as well. But there is some electronic. You can actually get like electronic access if you purchase the book. It's expensive, but anyway, let's all sell on Briggs for now. But it does give you a nice summary of the information. It'll tell you, a general recommendation. It'll talk about the studies and trials. So there are other references that support this type of information, but I find that Briggs is probably the most comprehensive out there. So if you don't have your own copy, maybe you can see if your place of employment would be willing to purchase one. That's not a huge investment. And some of the things just to think about is that the data can be really all over the place. Some drugs might have really extensive reviews. Other drugs might have virtually nothing. A lot of the data is not really high quality because, again, we aren't doing randomized control, placebo-controlled trials on pregnant people. In a lot of those cases, it's not ethical to do that. So you just don't have a lot of times you're looking retrospectively and pulling data from meta-analysis and looking at correlations and stuff. So it's not always the best. And every once in a while you get these knee-jerk reactions where somebody correlates a ton of data from some big database and says, well, this drug is causing cleft palate in 1% higher than the general population. And then 2 other people do a meta-analysis with different databases and find that's not the same results. So it's hard to replicate some of this data too. But we work with what we have, so always err on the side of caution, I think, is a good rule of thumb, especially with pregnancy. And then new drugs. New drugs is a big issue too. Most drugs aren't studied initially in pregnancy, because there aren't a lot of new drugs being developed for pregnant-specific complications or diseases or anything like that. And then when they come out, they might have some minor data, and then usually what's going to happen is people are going to use it out of necessity, and eventually they'll do, again, retrospective analysis on those people that tried it and see if there's any birth defects associated with it. So not the best system, but again, we work with what we have. So the FDA pregnancy categories have technically gone away. However, they're still heavily used and discussed, and people rely on them in practice. So this is what they end up breaking down, in case you're curious. So category A, first of all, there's very few medications that are actually category A. There's only like 1 maybe that I can think of for sure. There might be a couple. There's a handful. Let's put it that way. Not many. But it says controlled studies of pregnant women show no risk in first trimester. Again, there's very few controlled studies in pregnant women. B, animal studies show no risk, or animals show risk unconfirmed in humans. So B could be really a lot of things. So that means that they've done extensive studies in animal models that show that it's not teratogenic, or they've had a study done in humans that hasn't confirmed risk, but maybe animal studies actually did show risk. So you've got animals showing risk, but maybe they've done enough data in humans to say that, yeah, we think it's okay and not going to translate over to humans. C, animal studies show risk, and really there's nothing else we know about it. C is probably the most common category you're going to see, and that's just the nature of the beast. A lot of times when they do these animal pregnancy models, they're giving them really high doses that don't really translate to what we'd give a normal person, so it's really hard to correlate that. But if you have an animal model that's showing risk, you might want to take it seriously. But C is sort of risk outweighs benefit, right? A lot of times that's what this comes down to. Is the risk too great, or does the patient really need to be on the medication? D is evidence of risk to the human fetus, and benefits may outweigh risk of serious conditions. So again, D is probably some decent or somewhat decent data that shows that there is likely a risk, but in certain cases we could still use it. X is outright teratogenic when there really isn't any useful purpose to giving this medication. The other thing about category X to think about is usually there's something else that you could give in place of it. So maybe, like for example, statins are category X, but you can lower cholesterol with some other medications. Not quite as good as statins, but we can replace it. Now, if there's something that is essential that maybe has some birth defects, like what we talked about. We talked about maybe some anti-epileptic drugs like Valproex that has known birth defects. Well, if somebody's totally managed on their seizures, has tried tons of other anti-epileptic drugs without success, it might be to the patient's benefit to keep on it, even though there is a small risk of birth defects. So you run into those situations. So that's why like Valproex is a category D. And you get splitting hairs in some of these cases, but some things are outright teratogenic. Most things you're going to see are going to be B, C, or D, with C being the most common one. And then so I said these letters went away technically, and that's true. In June 30th of 2015, they decided to phase out everything gradually. So any new drug approved has to have some different information with it. So what they're going to do is define things in categories. And they're going to be these 3 categories. So pregnancy, lactation, and reproductive potential, which is new and kind of an interesting way to look at it as well. So they're requiring the FDA is requiring drugs to have some sort of data on this, and usually it's animal studies or animal models that they're going to be reporting, and very small amounts at that. But they have to be able to have some statement on pregnancy, lactation, and the reproductive potential. So there's no real letter, which a lot of people are kind of bummed out about. It's nice to have that letter. You're like, oh, is it A, B, or C? It gives you at least kind of a frame of mind to go into it, especially if you're going to go review extra literature on it and see what the data actually supports. It's nice to know, well, what are we looking at to begin with? So there's no just blanket statement, but it is supposed to provide more of a detailed summary. So saying like pregnancy, yes, it's generally thought of as good, here's why, type of a thing. So again, requiring you to use a little bit more reading comprehension in your brain more than just looking at a letter, which is probably good, but at the same time, those letters and just having like a category X, you're like, whoa, that looks really bad, right? Whereas if you have to actually read that it's category X or whatever they're going to define that as in these new settings, you actually have to think about that and go through and look at that. So there's pros and cons, I think, but the nice thing is that new drugs should have a bit more comprehensive data out there than other than just, you know, a category letter and then maybe some really wishy-washy data. We'll see how this takes off. You know, the drug pipeline is not super heavy right now in production, so we haven't seen a lot of this come out, but you know, as things go forward, we might see more and more of this. But for now, the letters are still pretty commonplace. And it's not like they removed letters from the current things. The current drugs out there all still have their letters attached to them. This I don't really care, you know. This is Australian category, so in case you're curious, like some drug databases will report the Australian system. I like it because it's a little bit more stratified, and it has different categories within B. So there's B1, B2, B3. So oftentimes you might look up a drug in a monograph and it might say US category C, Australian category B1. Well, what does that mean? Well, it means that drugs which have been taken into a limited number of pregnant women, childbearing age without an increase in frequency of malformation. Well, that sounds a lot better than the US category, which is C, which doesn't support that. So it just shows that sometimes in different countries there might be different studies that support things, and maybe the US system isn't always as up to date, or maybe the Australian system doesn't take into consideration US studies too. So it goes both ways, of course. But anyway, they stratify it more, which is nice, I think, in some cases. Otherwise, it's pretty similar. Germany has a totally different system too, in case you're curious at how European countries do it. Oops, change it here. So they have a different grading system that's a little bit more confusing than the letters, but you know, just out of curiosity, in case you wonder what other countries do, that's what they do. As far as tests, I do want you to know the FDA letter categories, so I will give you a statement and say which letter does it match up to. I think it's really important because, again, you're going to hear people use the letters all the time, and if somebody says, well, it's category B, it's fine, I want you to really know what that actually means, or what they actually define that as. Okay, so if pregnancy was challenging to make recommendations on, lactation's worse. So a lot of drugs are excreted into breast milk, but we don't really know how much. And there's a lot of metabolism losses along the way. So if you think about the way a drug moves through the body, you know, it gets absorbed through the GI tract, you already lose some of it there. Bioavailability from oral routes is likely not 100%. So you lose some there. It might go through first pass metabolism. There might be some blood esterases that break some of it down too. Time it gets to the breast milk, question is, like, how much is in there? Well, theoretically, if it's crossing over small molecule, should be about the same concentration as would be in blood, but that's not always the case. Some molecules that are highly protein bound are much more likely to stay in the serum and not go into the breast milk. Molecules that are really big, like vancomycin, for example, antibiotic, large glycopeptide, doesn't really get into breast milk. What other things are there? There's molecular weight and albumin binding are probably the biggest two that are going to affect it. So while you have this general rule of thumb, there's lots of exceptions. What does this mean? Well, it's a case-by-case basis. And again, this is something I would look up every time. You know, there's a lot of older medications out there that end up getting preferred in breastfeeding just because we have data to support that they are safe in breastfeeding. Or we have good data to support that they're excreted in really low volumes. So you'd be surprised that there is some data out there, especially in really common conditions like postpartum depression. There's a lot of data to support that sertraline, for example, doesn't get excreted into breast milk as much as citalopram. Now, is that clinically relevant? No one really knows, and probably not. But you know, if you want to err on the side of safety, there is some data like that out there. When in doubt, if you don't have a lot of data, pump and dump. If you're concerned, you know, unfortunately, having my wife breastfeed 2 kids, I understand the fear behind this, or the fear of regret and losing that liquid gold, right? But you'd rather have that than poison your child, correct? So, you know, at the same time, it's something the patient can consider too. If they're like, well, I'm comfortable with it, you know, you just have to provide them with the information. The American Academy of Pediatrics has a bunch of statements on things that are okay or not okay in breastfeeding. And this is sort of good and bad because sometimes you'll read this monograph and it might say, well, this study says that it excretes into breast milk, it might have the following defects, etc. And then the American Academy of Pediatrics says it's okay. Well, what exactly does that mean? But they usually list things as okay or not, and so they'll say some things are contraindicated. Of course, you don't want to take methamphetamine or drugs of abuse or cocaine, but some other things that aren't all that relevant. Following relatively safe things, moderate alcohol, interestingly enough, American Academy of Pediatrics says that's okay. Analgesics, antibiotic, anticonvulsants, moderate caffeine, insulin, laxatives, all those things they consider. I like how they lump analgesics into one neat package because they're all the same, right? But, yeah. Anyway, so you might see statements like the AAP says such and such is okay, whatever. It's a little bit of how much is the patient taking? You always have to consider those things too. All right, some other things that might be relevant to nursing mothers, drugs that can decrease milk supply. Basically, a lot of this stuff isn't super common, but anticholinergic meds are probably the biggest ones on there. Benadryls might be the biggest culprit that somebody might be likely to take in the postpartum period for allergies or sleep or something that could potentially decrease milk supply. It's not a hard and fast rule, but it's possible. Drugs that can increase milk supply, not that we prescribe people like amoxicillin, which is a really weird antidepressant no one uses, or antipsychotics to do this. Some drugs like methyl-dopa, metoclopramide, and reserpine, which is a really old antidepressant or anti-hypertensive agent, can actually increase milk supply. So I don't think I've ever heard of anyone taking these medications for that purpose. That'd be a little bit extreme, but it's there in case you're curious. Some other tips. So drugs with shorter half-lives are better. The longer it stays in the body, the longer it's going to stay in the breast milk too, and the longer it's going to take the infant to metabolize whatever they're consuming. And think about it that once it gets a certain concentration in the breast, it's going to be ingested by the infant, which is going to go through their metabolic system. And while infants have, interestingly, very leaky GI tracts in the early stage, by leaky I mean large things can get through. So even if you're like, well, there's no way this drug, which is a large molecule, could actually be absorbed by the infant. Technically it could, because maybe even large proteins could get through an infant's GI tract relatively unmetabolized. But by the time they're a few weeks to a month old, it shouldn't be as big of a deal anymore. But anyway, we do take that seriously, and we try and use shorter half-life drugs because the infant's metabolism process and their liver function isn't just up to par right away. We want to make sure we're being careful with that. Administer the drug immediately after feeding or before a long sleep period. And when in doubt, if it has a pediatric indication, it's probably okay to use, right? So that's one thing that I think people forget about. It's like, yeah, we use this in kids all the time. So should you still check it? Probably, especially if they've got a 1 or 2 week old baby. But generally speaking, a lot of drugs out there that we use in adults are fine to use in kids. And a lot of drugs are fine to give to breastfeeding women. There's a few exceptions that I'm not going to go into, but again, case-by-case basis. And if the mother's ever uncomfortable, a pump and dump is always an option too. So. All right. Questions on pregnancy or lactation? Yeah.
Are there any super common ones that are just absolutely no-go?
The one that I can think of is somebody taking pictures. Like a Snapchat or something. So the one that I can think of that I've seen occasionally is aspirin. So we had somebody in our emergency department who maybe had a type of a coronary event possibly when she came in, and we didn't realize she was breastfeeding. And on every woman under age 40, you get a breastfeeding flag when you order a medication. It's noise essentially, and it's really annoying because they just don't enter it right. But anyway, so I clicked through it. The doctor clicked through it who ordered it. The person got the dose, and then turns out, yeah, that's probably not a good idea because any amount of salicylate can possibly lead to Ray's syndrome, even though it's super rare. So it's still the same thing. You don't give aspirin to kids under 16. So that's one that I would say is kind of a hard and fast rule. If somebody's having a coronary event, I would say definitely give it, just pump and dump. And remember, you can always get rid of the drug by doing that. So we had to tell her to pump and dump for a day. She actually took it well, fortunately.
When you say pump and dump, what kind of time frame are you?
It depends on the half-life of the drug for the most part. Yeah, and you wouldn't necessarily even have to dump if you could hold off. So that's why it's good to do it right after a feeding, because it takes your body a while to rebuild the milk supply, and you can probably go longer. So that's why short half-life right after the feeding. If you have a drug like something that's got a day or two half-life, you might have to wait that long to do it and tell your body. So you're going to be dumping that whole time. But if it's only a couple hours, you might be able to go without dumping it all. And by the time your body clears it, it's cleared from the breast milk too. So it's not like it just stays in there and never leaves. Yeah. Questions? I saw a hand. No. Just imagining things. Okay. All right. Okay, so let's talk about some common pregnancy-related things. Morning sickness. A lot of these things are, self-help type things or over-the-counter. So it's not really the hardest medicine we're going to be talking about today, but all of it's, I think, important, especially if you're dealing with pregnant patients. So nausea and vomiting, super common, especially in the first trimester. The cause isn't really known. There's a lot of speculation about hormonal fluctuation and esophageal sphincter relaxation with increased estrogen levels that can cause, acid reflux too, which can also lead to nausea. But generally speaking, we don't exactly know what's happening here. So I want to differentiate two things, morning sickness and hyperemesis gravidarum, which is really severe nausea and vomiting during pregnancy, which can lead to malnutrition and dehydration. So that would be a much more severe case for patients. I've actually seen pregnant patients come into our hospital on parenteral nutrition because they cannot tolerate any oral intake because they're so nauseous. So you can get that severe, which is really rare, but it's possible. So what do we treat the rest of the people? So I'm not going to focus on that right now. We'll talk about parenteral nutrition a bit during critical care later this summer. But first, let's talk about some non-medical options. So saltines, so bland food is always something worth trying. Preventing the stomach from being completely empty has been shown to work for pregnant patients. So small meals, again, the stomachs, especially in the first trimester, not as much, but if they're still having nausea into the second and third, as the fetus kind of pushes into the stomach and shrinks its size, smaller meals can be more efficient than eating a larger meal, especially from a nausea point of view. And avoiding things that are obvious triggers, like spicy things, or maybe spicy things work great if you want to eat more spicy food. Good. Just avoid things that make you nauseous, right? That's easier said than done, of course. Okay, so what treatments do we have? The preferred category A treatment, which I kind of laugh about, is this combination of doxylamine and pyridoxine. Some drug company thought they were really smart, and they combined it as a product called Diclegis, which is a delayed-release combination. Please don't ever prescribe Diclegis to anyone. Diclegis is really, really expensive, and you're going to charge your patient a lot of money for two over-the-counter medications that cost pennies individually. So all your patient has to do is buy doxylamine over-the-counter and buy vitamin B6 over-the-counter, and they get the same thing. Now, the dose isn't exactly the same, but you can kind of fudge it and figure it out. Look at what Diclegis is if you really want to dose it off that. It's pretty similar, though. So anyway, this is category A. This combination has been studied and has been shown to be somewhat beneficial in preventing morning sickness in pregnant patients. So it is first line because it's benign. You can't do any harm with this regimen. I mean, you could take a ton of doxylamine and probably get some side effects, but generally speaking, it's a really well-tolerated medication. It is a first-generation antihistamine. It's a short-acting sedative. Think of it like a mini version of Benadryl. It's not going to have a lot of effect on the patient, but it might have, a little bit of sedation associated with it. It's also preferred as a sleep medication in pregnant people too because of its sedative. My wife tried it; she didn't get any effect from it. Just personal experience, but it is an option. It should be sedating, at least on the sedating spectrum for most patients. Category B and likely okay, meclizine, which is an anti-motion sickness medication mostly, but that could work potentially for this too. Diphenhydramine or dimenhydrinate, so our first-generation antihistamines, again, are still working for this. You could try diphenhydramine. Again, more sedating, more anticholinergic, more side effects. Metoclopramide or Reglan is category B. Promethazine is also category B too. Zofran or ondansetron is category B. I think I kind of mentioned this, but we'll talk about it just quickly again. This is one of the ones where I was mentioning there's a big controversy with as far as the data goes. So there was this meta-analysis that came out a while ago that said it increases the risk of oral facial clefts and possibly cardiovascular malformations in developing fetuses. There are a couple other follow-ups to this that showed that it wasn't as significant as we originally thought. In fact, one of them said that there was no difference at all between the general population. So Zofran's kind of a question mark right now. There's data that says, yes, it does maybe have a slight increased risk. And we're not talking about huge percentages. We're talking about very small absolute risk here, but still statistically significant. And between the different sets of data out there, there just isn't a consensus yet. So the safe recommendation is that you bump Zofran probably all the way down to the bottom. Still use it, and you still can use it. However, we prefer using like Benadryl, metoclopramide, promethazine first. Generally, don't use prochlorperazine. Promethazine's in the same class, should work relatively the same way. If it didn't, and you wanted to try later prochlorperazine, you could. Just remember to wait enough time. You don't want to give those two right away, so they can cause the EPS-like movement disorders. You can also try steroids too. Methylprednisolone might help in some patients as well. It's category C. Steroids are a little bit wishy-washy. They've got data that maybe says sometimes they could cause cleft palate, but that's really unusual. And in small doses and in short courses, they're likely pretty safe in pregnancy. And then if you want to get something herbal for your patient, ginger, either in aromatherapy form or like ginger lozenges are pretty popular products too. Ginger has been actually studied and proven to work for this too, so you could try that.
Yeah. Things like the Doxy or the Benadryl, you take that because they're a sedative. You take it at night before you
Yeah.
sleep, and then it'll supposedly take away the morning sickness, or you take it when you are sick in the morning.
That's the problem with Benadryl for this. So you probably have to, it depends. Some people might not get all that drowsy on it, and that'd be fine to take it during the day, but most people are going to have this going on throughout the day, so that's why doxylamine's not as sedating, and people can usually take it during the day without falling asleep, some people. But yeah, Benadryl probably not going to be an option for round the clock, but it could be a good bedtime option for nausea at bedtime. It's definitely going to limit its use, which is why like metoclopramide, Zofran even would be better options. All right, heartburn can go hand in hand with nausea. Yeah, you like that drum? So again, we talked about this. The uterus gets enlarged, you get pressure on the abdomen and stomach, and you've got a number of options here. So non-medical options are very similar to how we treat non-pregnant patients. There's no different here. In symptomatic treatment, we're going to focus on trying antacids first. They don't absorb systemically. And anytime you can give a pregnant person something that doesn't absorb systemically, that's effective for their condition, it's going to be beneficial or preferred over something that absorbs systemically. You just have no risk with drugs like Tums or Mylanta. A little extra calcium, well, generally speaking, a little extra calcium never killed anyone. A lot of extra calcium, sure, but not a little bit. Sulcrafate is that medication that kind of coats the stomach. It can work too. It's fine in pregnant patients. Doesn't absorb systemically. And H2 blockers, especially ranitidine, is very well studied and very low risk. So that's certainly one that I think most people would probably go to right away. I would recommend, unless your patient really has very mild symptoms, they're having pretty severe heartburn, or, not severe, I would say, but mild to moderate even, and pretty regular, consistent heartburn throughout the day, I'd go straight to the H2 blocker. Give it a couple days. If that's not working, go to the PPI. PPIs aren't well studied in pregnancy, but in the limited data we have, they're thought to be pretty safe, and they certainly do use them in pregnant patients because this can affect nutritional intake, which can affect the developing fetus a lot more than probably the PPI could. So, at least from the data we know. Constipation can be caused due to decreased peristalsis throughout the GI tract. So, and similar to non-pregnant patients, we're going to treat with the same non-pharmacologic options. And symptomatic treatment, bulk laxatives, surfactants like Docusate are fine in pregnant patients. When you get to stimulant laxatives, you want to be careful. Like with Senna and polyethylene glycol, they generally aren't preferred, but could be used in severe cases. Mineral oil isn't something we generally use all that much, but I did put it on here because you want to avoid it. It can cause vitamin K malabsorption, which when you get close to delivery can cause hypoprothrombonemia, which can put the infant at risk for clotting, lack of clotting factors leading to increased bleeding risk. So that's why if you've ever had a baby or been around when a baby's been born, they give a shot of vitamin K right away, and that's so the body can upregulate clotting production factor immediately. That's just to prevent this from happening, but mineral oil can impair that absorption in the mother, which can augment that possible problem. Hemorrhoids can be caused due to the pressure in the area and causing varicoses in the anal canal. Constipation also can compound the issue. Correcting the constipation is usually helpful. Tux pads are pretty common. When you have things like low-potency corticosteroids or other topical anesthetics like lidocaine products, I'd refer them to GI, or not GI, but OB. If you are OB, then you can refer them to yourself, I guess. But you can do the research to figure out if that's something you're comfortable with. Generally speaking, from what I've read, low-potency corticosteroids like hydrocortisone are fine. However, you do risk some systemic absorption, and there is a slight risk of birth defects with steroids, like I mentioned earlier. So again, low risk, but still some risk, whereas like Tux pads have no risk. Anesthetics like lidocaine can be okay, but you just want to make sure they aren't getting into like absorption, which they can absorb through the through the rectum. Same with corticosteroids. So we do want to be careful with that. Okay, headaches. Headaches are pretty common, especially, and we're talking more about new headaches here. People with existing migraine disorders could get worse migraines with pregnancy, and we're probably going to manage them similar to what we would normally. But if it's a new headache, we're going to focus on basic stuff like ice packs or new headache disorder. Ice packs, acetaminophen will be tried. As far as like better options than that, you have your antiemetic group that can work. So promethazine and metoclopramide again. High-dose glucocorticoids can be an option, and narcotics are safe in pregnancy. We just don't like getting people hooked on narcotics, but it is something you could consider trying. Drugs to avoid, aspirin and NSAIDs, especially if you're greater than 30 weeks, we're going to avoid. NSAIDs can be used sometimes during the second trimester safely. There's some data to support that, but usually during the first and third, you're probably going to avoid it. Triptans, I know I said these are a big no-no in pregnancy during the headache lecture. However, there is some data that's conflicting on that. So animal models generally show that it's problematic to give these to developing fetuses and that it's teratogenic. But there hasn't been a lot of good reproduction of that evidence in humans. And specifically, there's been a couple big retrospective analyses done in Scandinavian countries, like one in Norway and one in Sweden or Denmark, I can't remember which one, but it doesn't matter. But anyway, they looked at big pools of data, and they didn't actually find any increased risk with people that use triptans, and they looked at thousands of people. So it was a pretty big pool of patients that they reviewed, and they didn't find anything out of the norm compared to the general population. So I have seen triptans used. I think it's just a caution type of thing. If the patient's going to get relief from it and nothing else is working, it's probably fine for the most part. DHE is most likely not okay, so I'd stick to the triptans. It's just not well studied in pregnancy at all. Respiratory problems can occur due to increased nasopharynx blood flow and elevation of the diaphragm due to the uterus. And you can get hyperventilation due to increased progesterone levels. This can be problematic because it might just be pregnancy-related symptoms and nothing really wrong with the patient that's causing the presentation of a respiratory-like illness. And so you really have to use your diagnostic skills to weed that out. And basically, treatment strategy for anything respiratory is going to be the same as something a non-pregnant patient, how you treat them. So pneumonia, common cold, sinusitis, it's all going to be really the same. We're focusing on using things like acetaminophen for the pain-related symptoms associated with it, focusing on beta-lactam general classes, so penicillin, cephalosporins are okay. Avoiding generally like fluoroquinolones and tetracyclines if you have to use something anti-infective. But for the most part, you have a number of options here. As far as symptomatic relief for just like stuffy nose, you want to avoid constricting mechanisms, so things like Sudafed, topical preparations even like oxymetazoline or Aspirin or topical phenylephrine. Even though the idea of them getting systemically absorbed to actually affecting anything substantially isn't likely, it's still something that people err on the side of caution and won't use. Intranasal glucocorticoids like Flonase or fluticasone work quite well for this. The problem is they take a few days to start working nicely, but it's better than nothing for a lot of patients. And again, the vasoconstrictors are something we try to avoid.
Chad, I feel like my pregnant friend specifically takes it.
Really? I think it's not like an absolute contraindication, but it is something that they try to avoid. I've had a couple instances where we've had somebody and they ended up getting OB involved and they were like, no, nothing vasoconstrictive at all. It could just be the practitioners we have at our hospital. Some people might be fine using it. Again, it's probably really low risk, but they think that anything possible alpha constriction can decrease placental blood flow, and that's a risk that they don't think is worth taking in some cases. So it's all about the provider and how severe the symptoms are. If nothing else is working and your patient just needs to get some relief and some sleep, then maybe it's worth trying something like that. All right, coagulation disorders. So this is, of course, common. We talked about this with our hormone replacement therapy and how that increases the risk. Well, pregnancy increases the risk substantially due to the increased estrogen levels. So people with a history of DVT-PE are at really high risk. Other risk factors are listed there. Treatment options are pretty limited based on what we've studied. So heparin if somebody's inpatient, they're probably going to get IV heparin or sub-Q enoxaparin. Those are going to be the two common ones. You can give heparin subcutaneously outpatient. It's just kind of complicated. It doesn't come in an easy, nice pre-filled syringe like enoxaparin does. You'd have to draw it up in vials, and the dose is really weird. So most people like enoxaparin because it comes in all these different syringe strengths. It's pre-drawn for you. It's kind of idiot-proof. You can't really overdose yourself with it. And dalteparin is the same way. It's just two different brand names. Enoxaparin has been generic for a while, and it's a little bit less expensive, so it's probably the more common one. But both of those are fine in pregnancy. Those heparin molecules are so big, they aren't really going to cross the placenta. They're not going to cause any risk that way. Avoid warfarin at all costs. That's not something we ever use. The new oral anticoagulants all have possible, I think, hope maybe for pregnant patients, so we don't always have to use injectables. But right now there's no data, not enough data anyway, that's been published to support that. I think we might see some of that change in the future, and I hope we do, but at least for now, we can't recommend them for that indication. Gestational, we talked about this a little bit, but just to review, insulin, oral options, glyburide, and metformin are the best studied, and those are all fine. So usually we're looking at those two or insulin. We don't really use any of the new oral hypoglycemic options. They just aren't studied at all. Okay, hypertension. So going back to cardiology a little bit and talking about hypertension. So with gestational hypertension, you have blood pressure over 140/90. You can have proteinuria or pathological edema should be present. That puts you into a different category of the preeclampsia group. So that's what preeclampsia is technically defined as, just that hypertension plus proteinuria. Eclampsia is tonic-clonic seizures associated with high blood pressure. So that's the stratification there. And of course, we want to prevent anyone from going into eclampsia. So that's why preeclampsia, even though this is all it really is treated very aggressively and managed very closely, because if it goes into this, you can risk losing the pregnancy, you can risk losing the life of the mother. There's a lot of problems with, of course, getting major seizures. So it's something we treat, again, really aggressively. If somebody has chronic hypertension going into their pregnancy, so that's defined as existing before 20 weeks gestation, then you just want to usually treat them similarly, but we'll tailor their regimen a little bit. I'll show you how to do that. But chronic patients can develop preeclampsia. I don't know if there's a lot of evidence to show that they're at higher risk of actually going to preeclampsia, but there is, from what I understand, higher risk of them being more out of control during the pregnancy process. So we'll talk about some of the drugs here in a second, but I did put this slide on here in case you're curious about what preeclampsia with severe features is. So this is sort of the criteria they would use. I'm not going to test you on this, but in case you're curious to review that. Okay, so we'll talk about the more severe stuff first. So with preeclampsia prevention, there's a couple different things that are studied. And aspirin actually, because I'll go back to this other slide really quick. You can see that low platelet count is actually one of the criteria. So there's some thought that people might be in a point where they have problems with their platelets or some sort of an increased platelet turnover going on, and the aspirin can potentially help with that complication. The benefits are mild, and you want to discontinue about 5 to 10 days prior to delivery just to prevent the patient from bleeding out. So a baby aspirin, this goes against all conventional wisdom, right? We don't want aspirin during pregnancy, we don't want it in our kids, yada, yada, yada. However, with the low dose, it's actually been shown to be relatively safe and somewhat effective. However, again, the benefits aren't quite as good as actually just controlling the blood pressure. So if somebody has mild to moderate preeclampsia, we're going to treat them a little bit more aggressively. If it's appropriate, we want to get the baby delivered, so you might induce delivery. And then methyl-dopa has been the long standard for treating hypertension and hypertensive emergencies sort of in the OB world. Problem is, it's not all that effective in antihypertensive. So I put the other ones underlined because they're used much more commonly than methyl-dopa. Even though if you read a lot of resources, they'll say use methyl-dopa. We like labetalol, hydralazine, and nifedipine better. They're better tolerated, more potent, and generally just have less side effects overall for the patient. ACE inhibitors and ARBs are always going to be avoided. They're teratogenic, and they can cause some other issues too. So we just don't like them at all in pregnancy, so you can get those out of your mind. It's probably the biggest challenge with treating chronic hypertensive patients. Most of them will be on an ACE or an ARB, so it's transitioning them to a pregnancy-friendly regimen once they get pregnant. Severe treatment, high-dose magnesium sulfate, IV, is the preferred treatment. We give a few grams an hour, so we'll start usually at with a 4 or 6 gram bolus, which is a lot of magnesium, in case you're familiar with how magnesium is dosed and why would you be able to work in this area. But they end up doing magnesium for 4 to 2 grams per hour on a specific schedule. They do some mag monitoring. I'm not exactly sure the criteria for when they cut it off, but there is some of that involved too. But at this point, high magnesium levels aren't necessarily anyone's concern. We're more concerned with what's going on with hypertensive crisis, making sure they don't go into seizures. So that's much more important than getting high magnesium levels. The patient, if you're talking about pregnant patients, usually younger, healthier women, they're probably going to have not very many comorbid conditions, and their bodies are going to be prepped to clear that magnesium out very quickly. So ultimately, it's not a huge deal in the long run. You might say, why don't we use benzodiazepines? Well, benzos can be great for seizures. So if the patient actually has an eclamptic seizure, they're going to ramp up the magnesium and give them boluses of magnesium, but they are probably going to give some midazolam, which is something we just like in the hospital. It's easy, it's short acting, it works, or lorazepam. And if you're wondering why magnesium, why does it work? Well, you get peripheral and cerebral vasodilation, blood-brain barrier penetration is, or protection is quite good, and it generally has an interesting anticonvulsant property. It's not really useful for other types of seizures, however, so it's kind of strange. Okay. Chronic, just to review what's useful for chronic patients, it's all the drugs I just talked about on that middle point, but we're looking at beta blockers, labetalol, and metoprolol is actually okay too. Calcium channel blockers are not really well studied, however we use nifedipine a lot. Why they like nifedipine, I'm not sure. I think amlodipine would be fine too. Hydralazine and methyl-dopa are all okay. So pretty much anything within the calcium channel blocker class that isn't diltiazem or verapamil. And then your hydralazine, your 2 beta blockers that are studied, and methyl-dopa. So there's some options, not the greatest, but there's a few at least to mix and match. All right, let's take a quick break. We'll do 10 minutes and come back and finish up the rest of the slides. So, good breaking point. We had the kind of all the pregnancy, lactation stuff, and now let's talk about labor and delivery and some of the specific aspects of that. So, the preterm labor is something that, of course, can be highly problematic, and we want to make sure we're managing it appropriately. So, the definition: term labor is generally thought between 37 and 40 weeks. And preterm labor would be your uterine contractions with cervical changes prior to that 37-week mark. Now, sometimes it's okay if they're a little bit before 37, let them go. In fact, we can keep little preemies alive that are 22, 24 weeks, maybe even a little younger than that. Pretty crazy sometimes, actually, how good our technology is now. But anyway, that's not ideal. So non-pharmacologic treatment, bed rest, hydration, and if they're smoking, which they shouldn't be, but they may be, that is something they should stop because that can induce preterm labor as well. Some prophylaxis, possibly. IM progesterone every week between 16 and 36 weeks. These are for patients who are really high risk, so if they have a history of preterm labor, or maybe other risk categories, maybe they smoke, or who knows. But there's a product called Makena, hydroxyprogesterone, which is just an injectable IM progesterone product, kind of similar to the Depo-Provera, although it doesn't last quite as long. It's not a Depo shot, it's just a more, it absorbs to the muscle quicker, so you get more instantaneous blood levels. And there's also progesterone suppositories that could be used on a regular basis that are administered rectally, they get absorbed systemically. Tocolytic drugs are also used to inhibit uterine contractions. There's a number of different ones, and the point is that they're just going to stop smooth muscle from contracting the uterus specifically. Terbutaline, I put as the first one. It's the oldest drug, and it's probably not the most commonly used one anymore. In fact, we prefer a lot of other ones over it. But what it is, it's a beta-2 agonist. It relaxes bronchial and uterine smooth muscle at the same time. It doesn't have much effect on beta-1 receptors, so fortunately you don't get a lot of heart rate changes, which is good. It's not actually FDA approved for labor, interestingly enough, although this is the primary use of it. And technically, you could use it in an asthma exacerbation too, but we use a lot of other things for that as well. So you can give it IV or sub-Q. The oral product doesn't really work, so it's going to be parenteral. and you can't really use it for more than 48 hours IV. The problem is you get eventually it accumulates, and while in the early phase of giving the drug you don't get a lot of cardiovascular effects, it does accumulate over time. You could possibly push it over into beta-1 activity. It does have some effects on the beta receptors in the pancreas, which can have things like hyperglycemic effects, and hypokalemia can be caused too due to some other effects related to that. There's cardiac arrhythmias that could possibly happen due to the beta receptor blockade, and then worse things from there. So generally speaking, that'd be rare and unusual to get those side effects, especially if you keep it within the 48-hour term. So the problem is if you need to go beyond 40 hours, like, well, what do you use then? So that's why terbutaline is not the best drug, and it's sort of limited its efficacy because of this. It can work great in the short term if you want to delay labor briefly, maybe while you get things under control with some other drugs, but for a long-term strategy, it's not the greatest. So magnesium would be another drug that would be very safe to use more in a long-term situation. So what magnesium does is you get kind of a functional antagonism of intracellular calcium contractility in the smooth muscle. Remember, magnesium generally relaxes smooth muscle, and in this case, the uterine smooth muscle. And it's useful in eclampsia too, so if you have a preeclampsia patient, also in preterm labor, you get a double bang for your buck that way, which is always nice. And there's not really any glycemic effects or cardiovascular effects, so you don't really have to worry about that like you would with terbutaline. So magnesium's looking like a pretty good choice, and it's actually one of the most common drugs used for this for that reason. Indomethacin is an NSAID, of course. It inhibits prostaglandin synthesis, just like all NSAIDs. And prostaglandins are thought to contribute to uterine contraction. So why indomethacin over other ones? I can't answer that. I think it's probably indomethacin was studied. They do give it rectally, so there's maybe some theory that while it absorbs systemically, there might be some local effect too. Maybe it gets to the uterus faster than chemo. I don't know. Kind of just making this up, other than just theorizing. So as far as NSAIDs go, really any of them should work, but again, indomethacin was studied, so that's the one we use. So anyway, indomethacin suppositories are pretty common in this patient population. Contraindications would be standard for NSAID: platelet bleeding issues, hepatic or renal dysfunction, GI ulcer disease. In gestation over 32 weeks, you risk possible complications with pregnancy. So you don't want to use for more than 72 hours total, because you can risk GI bleeding and other things like that, just because it's usually a higher doses of what you're giving. Again, this works well to delay for a few days, but other than that, you can stop maybe a preterm labor in its tracks, and maybe it doesn't recur, which would be helpful. But if you have sustained preterm labor, it might not be good for the long term. Nifedipine is a calcium channel blocker. Ken talked about this with eclampsia, but it also can prevent uterine muscle contraction. And if you combine it with magnesium, you could possibly get a double hypotensive effect. But other than that, it's pretty safe. So this is a nice option to try out for patients. It's oral. It's pretty effective when taken orally, and it's got very few side effects associated with it. So the question is, when would you actually want to use any of these products? Well, somebody goes into preterm labor, 24 to 32 weeks. Indomethacin can work well to stop the preterm labor from occurring, and ideally, if you can sustain that without the drug, you might be in the clear for a little while. If indomethacin is contraindicated, or they're at 32 to 34 weeks gestation, nifedipine is preferred. And then terbutaline is kind of the second line post 32 weeks gestation. And then you could use magnesium really anywhere in here, especially if you have preeclampsia, you want to use magnesium. Okay, so let's flip gears. We talked about tocolytic agents, so preventing preterm labor. Now let's talk about inducing labor. So there's a lot of reasons why, as you can probably imagine, why you want to induce labor. Severe infections, bleeding, preeclampsia. Diabetic patients might benefit from not going too far past their due date, or maybe even a little bit early. Macrosomia, if they have 8 pounds, 13 ounces, is the cutoff for what they consider a larger than average newborn. So if the patient's or the child's already measuring large, they might want to induce labor early in some cases. Premature ruptured membranes, and if they go over 42 weeks. So induction agents, oxytocin is by far and away the most popular drug here. It's something that they go through like candy on OB for. So Pitocin the brand name. You'll hear it used as Pit a lot. This is something people call it a lot, but it's oxytocin. So oxytocin it's a synthetically produced version of our naturally occurring hormone oxytocin. And when pregnancy happens, or when delivery happens, or somebody goes into labor, oxytocin is one of the primary driving factors naturally that's going to stimulate uterine contraction and the birthing process and get that rolling. So you can do that artificially by giving them the drug instead. And usually it might be a little bit stronger of an effect than you get from just natural oxytocin release because you're giving it usually higher doses. So they might be a little bit more painful than a standard birth, but it does work. It stimulates uterine contractions. What it does is it activates G protein coupled receptors that trigger intracellular calcium. Think about the way magnesium works, and this is kind of the opposite. It's functionally different. And so you're getting intracellular calcium increase, which causes constriction and contraction. And it increases local prostaglandin production, which also helps with uterine contraction. It's IV only. Risks are that you can overdo it and cause uterine rupture. You can cause uteroplacental hypoperfusion, so you cut off your blood supply, which usually isn't a huge deal in the short term because there should be enough residual in the placenta for the infant to be okay, but can be problematic. And if it does go on for a while, though, the fetus could possibly get hypoxic, so you end up with distress that way. So it's possible if you're overdoing the oxytocin or you're trying oxytocin, it's not working, you end up with a C-section because you have a fetal distress situation going on. Methyl organodine or methergin is an ergot alkaloid that can increase tone, rate, and amplitude of contractions. Not really commonly used for this. We do use this more for postpartum bleeding, though, because it does have a really good constriction component and can clamp down those blood vessels in the immediate postpartum period. We'll talk about that here in a second. But some other induction agents, you can give prostaglandins. We talked about NSAIDs work great to stop premature labor. Well, you can do the opposite thing here. So dinoprostone is Cervidil, which comes in this picture here. You can see it. There's a kind of mesh, and it's sort of this matrix thing that is frozen, and it dissolves very quickly at room temperature and specifically at body temperature. So it's an insert, apply it directly to the cervix, and it can cause uterine hyperstimulation. May cause abdominal pain as well, but it can help induce labor. Misoprostol is a prostaglandin E1 medication, which can be given as a tablet vaginally, which is interesting because I'm not sure how it actually dissolves and absorbs, but it seems to work. But you can also give it PO for either two things, so for hemorrhage, postpartum. Otherwise, this is kind of known as the abortion pill. You can give it in really high doses, and it can abort an early or terminate an early pregnancy. Postpartum hemorrhage is managed with a couple of the drugs we already talked about. So pretty much everybody who has a vaginal or any type of delivery, the big problem is when the placenta detaches, you have a lot of blood vessels there. And normally there's some bleeding that's going to happen, of course, but when it happens in high volumes, you run the risk of volume loss, blood loss, and then you might have to replace those. You might even end up with a more severe situation like hypovolemic shock situation. So this is all done to prevent that. So most patients are going to get a big dose of oxytocin immediately following delivery, which is going to help clamp down all those blood vessels and keep the bleeding to a minimum over the next several hours while the body has some time to adjust. You can give misoprostol, PO, or I think that's supposed to be vaginally, not rectally. We don't give misoprostol rectally. Sorry about that. And then other things you can do are the methyl organodine, which we talked about on the other slide. There's also a drug called carboprost, which is another different type of prostaglandin. This is kind of in stages. So basically, oxytocin is your first line, misoprostol second, methyl organodine is third, carboprost is fourth. So anyone who has a baby at Abbott and most hospitals, I imagine, have similar things like this. They put in an order set, and it has all these drugs on it. And so it says if bleeding happens, use this for second line, use this for third lines. It's all specifically laid out so that the nurse knows when to give what medication. So that's pretty easy from an ordering perspective if you have been to work in OB ever, or working with OB patients. But yeah, these are the primary drugs, and really all it is trying to stop bleeding using a number of different options here. It's very similar to inducing labor. Because really you're just trying to promote contraction, which also usually helps with vasoconstriction as well. Cesarean section-related bleeding, surgical bleeding, that's different. Incision site bleeding, that would be managed like you would manage any type of incision site care post-surgery. All right, pain management. Narcotics are definitely okay during labor and delivery, and probably no other pain med's going to do anything during the actual labor and delivery process. It's just not going to happen. You could try something like an NSAID. Well, you wouldn't want an NSAID, sorry, but you could try like Tylenol, but good luck. No, we're not going to give you an epidural. We've got some Tylenol for you. Might get some angry women because of that. So epidurals, what are they? They're basically two components. So there's ropivacaine, which is the common one. Also bupivacaine is the older one. But remember our pain drugs, they're sodium channel blockers, and they block nerve impulses. So what this is doing is it's getting into the epidural space. It's going to decrease sensation to pretty much the lower half of the body for the most part. Now, it's not going to totally paralyze somebody because most people can move their legs a little bit. It kind of feels like should feel like they're numb or asleep, but they should still have some movement. If they're totally dead, not dead, but if they have their legs, they can't move. If they feel like they're dead below the waist, then they might, you might want to take it back a notch. But for the most part, it should be fine. Plus, usually there's an opioid use. So most epidurals use fentanyl, but they could have like a morphine one too. There's no reason why you couldn't. So fentanyl gets infused into that same epidural space. However, it's actually really lipophilic, so it gets out into the blood circulation and then ends up back into the central nervous system, into the brain, where we want our opioids to act, so it's decreasing perception of pain. So the fentanyl is a little bit of it's kind of like the sidekick to the ropivacaine. The ropivacaine is going to do all the work because that's going to really just decrease sensation. You aren't going to feel really much pain at all with that. The fentanyl is going to help with any maybe residual pain or aches you're having in association with the labor. Now, there's all kinds of debates about epidurals and so on. I'm not going to get into that, like the controversy of them. My wife's had them, just disclaimer with both kids, perfectly fine, they work great. So I'm a supporter, especially if it decreases pain. Well, the biggest side effect people can get occasionally is you can get really bad headaches with them. It's really rare. Otherwise, there's not a whole lot of side effects. If the access is done properly, and usually it's an anesthesiologist who's highly trained in this to do it, so you should be in pretty good hands for the most part. Intrathecal single shots can be used sometimes, and I see this done more during like surgeries potentially. So if you work, and do OB surgery potentially, you might see these used. So it's really a preservative-free morphine that's long-acting that's given into the intrathecal space. It's going to slowly, basically diffuse out of there and cause a delayed pain relief type system. So it's kind of just a strange long-acting IV pain med, really. You can also use fentanyl the same way, and it'll just absorb. You're just going to skip the ropivacaine. All right, fetal bradycardia, that's one of the biggest side effects to the fetus. So for moms, you aren't really going to have a lot of issues other than maybe some numb legs, maybe that headache post-epidural that's really rare. Ephedrine is a medication that releases norepinephrine from tissue stores. So it's kind of like a vasopressor, but a lot, I don't know what I want to say. It's not really a vasopressor because it doesn't act directly on your beta and alpha receptors. However, it does release natural stores of norepinephrine, so it kind of has similar effect. So you can give ephedrine, which can cause a brief period of vasoconstriction. It crosses the placenta, and it can help the fetus's heart rate kick back up into gear. So that's one of the biggest things that you'll experience with giving a patient epidural is that they're going to get maybe a decreased effect of heart rate with the fetus, which is usually temporary, usually comes back. And sometimes they can reposition the patient by rolling them a little bit and might spread out the medicine, help it diffuse more throughout the epidural space, or help the fentanyl get out more into the systemic circulation, maybe help get it metabolized faster so it decreases the exposure. But ultimately, it is an issue that can happen, and ephedrine works quite well. It is a controlled substance, like a C5. It's used to make methamphetamine. It's the same category as Sudafed, basically. And then post-vaginal delivery, you're usually using just scheduled NSAIDs. So people will be on like a scheduled ibuprofen regimen, usually 800 every 6 hours around the clock for a couple of days, and then maybe injectable ketorolac if they can't tolerate keto. As far as post-cesarean section, maybe you need some narcotics due to the incision site healing and the muscles that you cut through. Just because it's major surgery, it's going to require some more recovery that way.
Jim,
Yeah.
How long do intrathecal shots last before you?
It depends. If you give like a shot of preservative-free fentanyl, it's not going to last very long at all. Fentanyl's got a short half-life. If you give the Astramorph, it can last several hours because it's this formulated specifically to be a slow-release product that way.
So is it common to get like 2, 3, 4?
Usually
long delivery?
not. Usually you're going to do one of the Astromorphs or you do fentanyl boluses, yes. So you can do one or the other. You probably aren't going to do both, but maybe, I don't know. I don't get involved with OB surgery too much. It's not kind of getting outside of my realm of expertise. Okay, ID related stuff is important, so I want to go through it quick. Group B strep, or GBS as it's commonly referred to, colonizes GI and genital tract to about 15 to 40% of pregnant women. Mothers will never be symptomatic from group B strep in this area. However, you can get vertical transmission and neonatal infection rates from group B strep, or neonatal infections in general from group B strep can be devastating. Sepsis, meningitis, two of the most common causes of neonatal infectious disease are group B strep transmissions. So you get cultures at 35 and 36 weeks gestation. Positive women will be treated with intrapartum antibiotics. So usually we're looking at a beta-lactam. Penicillin works great. We also use ampicillin. It's just easier. It's an easily presentable product. It comes as like this little vial that you just hook up. And then cefazolin can be good for somebody who's got maybe an intolerance. If somebody has a really strong beta-lactam allergy, you could use clindamycin. But that's pretty much it. You should be able to get by with those ones. Chorioamnionitis, I think is how you say that, or chorio for short, is intraamniotic fluid infection, and it causes maternal fevers in the immediate peripartum period. And people who get chorio, it's strongly associated with neonatal sepsis and pneumonia. So it's really important we treat this quickly. And it's polymicrobial, so could be really anything. I'll show you this slide just in case you're curious. But most of the time you're getting a temperature of 100.4 elevated, immediate, and this is the mother we're talking about, in that immediate peripartum period, and treat with broad spectrum antibiotics. So we're looking at OB infectious disease, just for the record, is really weird. They use odd drugs and they use very short durations for the most part. So they're going to give doses of ampicillin, gentamicin, and clinda, all three of them, right away. And usually people are just going to get a single dose, and if they don't retain any sort of fever post that, like 24 hours later, probably not going to need any more. If they do continue to feel sick, you can, of course, continue the medication. Yeah, so that's basically, it's kind of odd why we just do one dose, but it seems to be very effective at whatever possible infection the amniotic fluid got and clearing that out as the body naturally clears that out itself. This is just the percentages of different bugs they find. And again, it's all over the place. From Enterococcus to E. coli to Bacteroides, so you get anaerobes and gram positives, gram negatives, lots of stuff. Yeah.
Does the baby get anything?
It depends. The baby probably just gets intense monitoring after that, but I don't think prophylactically they do anything. All right. Endometritis is another cause of postpartum fever, so usually 2 after the first 10 days postpartum, exclusive of that first 24 hours. So fever in the first 24 hours is most likely more chorio. Endometritis would be later on. And it's very similar. It's polymicrobial. Usually you're just using the clinda plus gent. You're skipping the ampicillin in this case. Or you could use just unison as monotherapy. It depends. B. fragilis is one of the more common ones that is thought to be the culprit here. And if you have good susceptibilities with your hospital's antibiogram to that, with unison, go for it. We have not good susceptibilities in Minnesota from what I know, so usually we're using clinda and gent for most patients. If they're group B strep colonized and you know that going in, unison should be fine because it should cover that for the most part. And that's probably what the issue is. Administer the antibiotics until the patient is proved, or again, afebrile for 24 to 48 hours, and you really no need to follow up any antibiotics after that. So again, short course, that's it. I don't care you know anything about TORCH, but it's just I just put it on there because it falls into the same category. It's perinatal infections with similar presentation, so rash and ocular findings, and it involves a number of different things, like mostly viruses and parasites or toxoplasmosis in that case. So there's some complications that it can happen, and it's on here in case you're curious. But again, I don't care that you know that. And that's it. So that's pericardium in a nutshell. I know it doesn't apply a lot to what you guys are probably going to be doing as a career, but you might see it come up, so hopefully somewhat useful. Just a quick thing, I did get the course evals, and I just wanted to say thanks for filling them out. One of the biggest things people said was that my turnaround times for exams, apparently I'm slacking off. Which, I will chalk that up to having 2 children and just call myself a slacker and be okay with that. But I get that we live in the world of instant gratification and immediate electronic feedback. So I'm not interested in doing my exams electronically, but I will try and be better about getting them to you faster this semester. How's that? Electronic exams in Moodle is a nightmare.